All right, we're ready to go. Very good. I'm very pleased to be with you tonight to talk about infectious disease considerations in transplantation, and I've got some real experts here that can jump in and help me because I may be a bit rusty, but it was fun to review this stuff again and try to pretend like I was a doctor again for a little bit. Now, is there we can do it that way. So just to sort of lay the groundwork, there are over 100,000 people that are waiting for transplants in the United States. We do about 21,000, and about 7,000 died while they were on the wait list. So there's a desperate need to try to increase the donor pool and obviously to look at other ways to support people who have end-stage organ disease. This is the data for Tampa General Hospital, the graft and patient survival by organ type. So you can see the 1 month, it's the observed over expected data. So our observed 1 month survival is for the graft is 97.58 compared to 97.77. The patient survival rate's 99 compared to 99.31. And we're really in the as expected range. We have had we were statistically significantly better than national averages in kidney and lung. Last year, we had a little bit of slip in these numbers, but these data are pretty old. It's about 3 years old in order to get 3 years of data, so it's not all that current, but we have good outcomes, basically. So we'll talk a minute about organ donation and how do we evaluate donors, what are the exclusion criteria, and some of this is very obvious to you. We obviously exclude donors who are HIV positive, have HDLV1 or 2, metastatic cancer, viral hepatitis, unexplained neurologic disease. Can you all think of some reasons that we would exclude patients who have unexplained neurologic disease? Exactly, and you remember that not too long ago, well, it's been a while now, there was a bad case where a woman came in with intracerebral hemorrhage, and they didn't realize that she had rabies, and so there were some people who had transplants that died as a result of receiving those organs. History of IV drug use in the past year, TB, malaria, and sepsis are considerations. Donors who are infected, if the infection is controlled before the organs are procured, then those generally are safe to use. And we have some technology now that we didn't have previously. The nucleic acid amplification tests can shorten the window period. You know, if you're using serology, then you may miss the window period before patients mount an immune response and not have positive serologies. But the nucleic acid amplification test can significantly shorten that window period and make it safer to use higher risk organs, although they still do recommend that if you use organs from higher risk donors that you get informed consent from the recipient. There have been significant advances in immunosuppression, so we have increased graft survival rates. These drugs all work by primarily depressing cell-mediated immunity, and so there's always a balance between the risk of rejection and the risk of malignancy or infection. And we really we have very crude ways of knowing how much immunosuppression to give patients. We don't have any good test that says this person needs X amount of immunosuppression and this person needs Y amount, so you know, we basically give everybody pretty much the same thing, and then we go, shoot, this was too much for this patient, and we make adjustments, and you know, that was not enough for another patient, and we give them more. So how do these drugs work? I'm going to talk a little bit about the drugs that we use primarily to immunosuppress patients, because it's important that you understand how they impact the immune system and what types of infections you'll see. So you all are very familiar with steroids. You see them used in lots of patients in addition to the transplant patients. They decrease the production of interleukin-1 tumor necrosis factor. They interfere with chemotaxis, and they decrease macrophage activation. So you have an increased risk for staph organisms, gram-negative rods, Candida, Aspergillus. You all have seen those complications, I'm sure. Azathioprine and mycophenolate have somewhat similar activities. They decrease T and B cell proliferation and the response of those cells, and they lead to decreased antibody formation. And nowadays, I don't think you ever see anyone on azathioprine anymore, so everyone's pretty much on mycophenolate. So you get a moderate suppression of the cell-mediated and the humoral immune responses. And one of the things that's important to know about these drugs is that they can reactivate latent virus. Patients are also given, in addition to steroids and mycophenolate, they get cyclosporin or tacrolimus, and I think 99% of the patients are on tacrolimus now. These drugs will decrease the production of IL-2 and gamma interferon and also decrease the response of the T cells to interleukin-2. It affects the T helper and the inducer cells. And these drugs promote viral replication. So Dr. Rubin, who's the guru of transplant infectious diseases, calls them, basically it's like PCR. So we give them drugs that reactivate latent virus, and then we give them drugs that make the viruses replicate. So it's not a good thing, not a good combination. And some reason this has made my my arrow go in this wrong place. But the thing that's really difficult, and we lost tacrolimus, but there are tons of drug interactions with tacrolimus. So, and a lot of the interactions are drugs that you guys use. So it's really important that you pay attention to this when you're taking care of transplant patients, because you can get into trouble. So the drugs which increase these levels are listed on this slide. Oops. So the ones that are really relevant to you, the macrolides, the protease inhibitors, azoles, can have these impacts, and it's important that you keep this in mind when you're adding these medications to patients' regimens. Drugs which decrease the tacrolimus and cyclosporin levels are listed on this slide. Most relevant would be rifampin, for your purposes, but it's important to keep that in mind when you're taking care of these patients. And then there are drugs which cause synergistic nephrotoxicity. So cyclosporin and tacrolimus are nephrotoxic drugs by themselves, but when you add these drugs, you get an additive, or it's really a synergistic, which means more than additive effect. Aminoglycosides, amphotericin B, high-dose trimethoprim sulfamethoxazole, the non-steroidals, ketoconazole, and cimetidine and ranitidine have this impact. Sirolimus is used in some patient populations, so you may run across that one as well. How much sirolimus are they using? You see it every once in a while? Yeah, not too often. Yeah, there are risks to using it early post-transplant because it can interfere with wound healing, and you can see why, because it decreases proliferation of all of these cell lines. So it decreases proliferation of vascular smooth muscle, endothelial cells, fibroblasts, all the things that you want working when you're trying to heal. But the reason we're using it is to decrease antibody production, the T and B cell proliferation, and that's the effect that we're aiming for. Yeah, that makes a lot of sense in that patient population. And this slide is a busy slide, but it just reminds you of the targets for the various immunosuppressive drugs. So the cyclosporin and tacrolimus act here at the calcineurin and prevent activation of these cells. The steroids act here at the interleukin-2 gene promoter. Sirolimus acts here, and the mycophenolate and azathioprine interfere with the G1 cell cycle pathway, so that it prevents replication of the cells. And this slide just goes over some of the toxicities. So you all are very familiar with the toxicities associated with corticosteroids, hypertension, hyperglycemia, osteoporosis, all of those fun things that occur when patients are on corticosteroids for prolonged periods of time. We'll skip over azathioprine, but cyclosporin and tacrolimus have fairly similar toxicities. Again, nephrotoxicity is a big one, hypertension, neurotoxicity, hepatotoxicity, hyperlipidemia, and hyperglycemia. So lots of different things to worry about with those drugs. Mycophenolate, primarily myelosuppression and GI side effects. Some patients, you'll think they've got, some sort of viral gastroenteritis or something because they'll have so much GI toxicity. Sirolimus results in hyperlipidemia and decreased blood cell lines, the platelets and red cells and lymphocyte counts across the board. We also use antibody preparations when we're taking care of transplant patients, and there are some different philosophies. Some centers use them to induce all patients at the time of transplant, and others use them more for rescue therapy. If a patient has rejection that's either very severe or not responsive to a steroid bolus, they'll use these types of therapies. Thymoglobulin is more commonly seen here, and it depletes the T cell lines, and daclizumab and basileximab are monoclonal antibodies that block the interleukin-2 receptors, and that's how they work. So some of the complications of antibody therapy with the older formulations, particularly OKT3, we saw a lot of serum sickness type syndromes and fevers, myalgias. People felt awful, and it was kind of tough because you go in to see the patient one day and they complain, they have a fever and a headache. So you're worried about, well, it could be meningitis or it could be from the OKT3. And then the next day they'd have arthralgias, and it's like, well, it could be, something infectious, or it could be from the OKT3. OKT3 also can lead to pulmonary edema and these other complications that I mentioned, but all of these drugs increase the risk of CMV infections and post-transplant lymphoproliferative disorder. Now, the other difficulty that we have is that these drugs blunt the immune response. So patients can present with very subtle manifestations of infection, and you have to maintain a very high index of suspicion for infection in these patient populations. They often won't have a very high fever. They may not have a lot of, if they come in with cellulitis, it's often not going to be a rip-roaring, case of cellulitis. They don't have edema. They may not have pulmonary infiltrates. So a negative chest x-ray in a transplant patient does not rule out pneumonia. You may need to get a CAT scan and do further investigations. And then the abdominal exam can be altered. So with all the steroids on board, they may not have point tenderness and rebound tenderness and the things that we use to help guide us in making clinical decisions. So now we'll move on to talk a little bit about the recipient criteria. You all still do the cardiac transplant eval work, so you probably get consulted to see these patients. And so why do they ask you to come see these patients pre-transplant? What's your role? So we'll talk a little bit about the criteria. The age ranges vary. So center to center has different criteria for what ages of patients they take care of. We do not transplant pediatric patients here. All Children's does, 1 or 2 a year. Although we do go down, we have transplanted people as young as about 16 years old. And various centers have different cutoffs for older age ranges, and it sort of depends upon their experience. Obviously, you have to have irreversible organ failure, and here you're trying to weigh, the risk benefits with the patient. So is it better to try to manage them medically for a period of time, or do they get a greater benefit by going ahead and being transplanted? Because there are, obviously risks either way. We need people with a stable psychosocial background. Yes, Dr. Montero is rolling his eyes. It's very important. These organs, as I mentioned at the beginning are in very short supply, so we want to optimize the chance of benefit. So we need to make sure that the recipient can follow a strict drug medication regimen, that they'll come in for their follow-up appointments. And the other thing that's difficult is that when you give people these high doses of steroids, even someone who's got a stable psychosocial background can become unstable. So you need family support and all of those things to be in place to make sure that this goes well. And then we evaluate the recipient for any significant systemic disease. So we want to make sure that we don't transplant someone, who's got a malignancy. And you guys are too young to remember, but, I think it was Mickey Mantle got a liver transplant and he had metastatic cancer and died. So it's a procedure that doesn't make sense, and then we don't have that organ for somebody else who could benefit from it. We want to make sure patients don't have active infection. It puts them at very high risk if we transplant someone with an active infection. And one of the things that the attending physicians get stuck with is making these decisions. So, they'll get a phone call at 2 o'clock in the morning. We've got a donor offer, but the patient had a fever of 101. What do we do? And it's no fun to have to say no, but it's worse to say yes and then have something bad happen. So you have to, and it's hard because patients get upset when they get inactivated. So it's not an easy decision to make, but it's important. For our cardiac program, they can't have significant peripheral vascular disease. If they can't walk because they have such bad peripheral vascular disease, then it doesn't make much sense to stick a new heart in them. A recent pulmonary embolus is another exclusion criteria. Irreversible pulmonary hypertension, the heart will fail in that situation. And then we obviously don't want to transplant someone who's still smoking and or using drugs or drinking excessively or things like that. And there's some surgical considerations. Has somebody had their chest opened up 3 times already? How difficult is it going to be technically to do the procedure, although our surgeons are fearless, so that doesn't seem to slow them down. So obviously we need to rule out active and acute infection, and we want to also think about latent infection. So, is there any history of tuberculosis, any exposures? Did the patient live somewhere where they might have been exposed to endemic fungi? Could they have been exposed to strongyloides? Do they have a risk for viral hepatitis? We rule out malignancy, and then we evaluate for evidence of any other systemic diseases. And in these situations, you guys are the ID docs and you're the internal medicine docs because nobody else is. So you got to wear both hats. We want to make sure their immunizations are current. So we update any of their childhood immunizations, and the newer literature supports giving varicella vaccine pre-transplant. Now, that's difficult. It's a live virus vaccine. We don't know when someone's going to get an organ. So if you have someone who's very critical and, high on the waiting list, you may think twice about that. But if you have someone that you think is going to wait, it's recommended. We make sure they have their hepatitis vaccines, and I should have included A as well. There would be no reason not to make sure they have that. Pneumococcal vaccine, obviously influenza, and we place a PPD, or you can do blood tests to check for evidence of TB exposure. Yeah. Yeah, I saw that as well. Yeah. No, it makes a lot of sense. So, I'm sorry?
What do you do with a positive interferon?
Yeah, well, I think you have to assume they've been exposed. So in terms of what you would do to prophylax them?
So change in prophylaxis.
You would actually treat them. And so the ideal thing would be to start treating them pre-transplant and hope you can get, yeah.
high prevalence of PCP.
Well-
Treat them exactly the same and we'll go for that.
Yeah, and if you can do it pre-transplant, that's ideal, as much as you can. The patient population that I used to get called about are the livers, because they have obviously end-stage liver disease, and then how are you going to treat them? So that was always a controversial one, but. And then you want to assess the recipient for any risk factors for infections post-transplant, because part of your job is to talk to these people and help them understand about how their behaviors impact their risk post-transplant. So, we want to talk about their travel and their domiciliary history. Where have they lived in their life? And that really plays into what, could they get, what could they reactivate post-transplant? So, were they in the San Joaquin Valley, or, are they in the southeast United States and they might have been exposed to strongyloides? What is their water source? A fair number of people in Florida have well water. So, that's important to know. And do they know if it's been tested and things like that? Do they have pets? What kinds of... one of my heart transplant patients raised parrots for a hobby, and that was one of the things he did. We had another one that went hunting in South America every year. So people have hobbies and occupations that put them at risk. We had a woman who was a neonatal intensive care unit nurse. So, you can imagine what she could risk at her job. We want them to have their teeth evaluated because we want to try to take care of those things ahead of time if we can. And then we get some baseline serologies to help us either decide, no, you're not a candidate because you're HIV positive, although we can talk about that a little bit, or what are your risks post-transplant. There are programs that transplant, that do liver or kidney transplantation in HIV positive patients if they're well controlled, if their viral loads are undetectable for a period of time. And that's really tricky because the drugs that you use to treat their HIV have significant drug interactions with the drugs used for immunosuppression, and it's a challenge to manage those patients appropriately. Post-transplant, we want to prevent infections. So what types of things do we give? We generally use trimethoprim sulfamethoxazole to prevent PCP mostly, but it has the side benefit of helping us with some of these other infections post-transplant. Valganciclovir can be used in patients who are either CMV positive recipients or CMV mismatches where they got negative recipient got a CMV positive graft, and it also will protect against herpes simplex. We want to make sure that we use CMV negative or leukocyte depleted blood products, particularly if you have a negative to negative patient. The acyclovir obviously protects against herpes. We want to teach them to avoid environmental exposures, and we want them to get an annual influenza vaccine. And one of the things that I always talk to patients and their families about was trying to make sure the family got vaccinated. The flu vaccine's not going to be as effective in them, but if we can keep the family from getting sick, then maybe we can protect the transplant recipient at the same time. And now, everyone's supposed to get a flu vaccine, so that should be happening anyway, but doesn't hurt to remind the family. And this slide got messed up too with this format. But so what do? You get called, you come see my patient, they've got a fever, what do I do? Well, it's what you guys do every day. You need to do a thorough history and physical. And these patients, you have to ask every question. You don't want to take shortcuts here. So you want to find out, about their water, about their travel, all of those things, their pets and those sorts of things. We want to get routine labs, your CBC, your LFTs, and so on and so forth, creatinine. You want to get the cultures, UA and CNS. We get a PCR for CMV generally in these patients. It may be appropriate to get a serum cryptococcal antigen to try to evaluate for that. May be appropriate to get a Legionella urinary antigen. And generally we start empiric antibiotics. And, we spent a lot of time talking about trying not to give people antibiotics inappropriately, and we don't want to treat, viral infections with antibiotics and that sort of thing. But we tend to be a little more aggressive with antibiotics in this patient population because you don't have much room for error, particularly early transplant. When they get, beyond 6 months, a year, and start getting more of the typical community acquired infections, you can, you don't have to be quite so aggressive, but we tend to be careful with these folks. And I am missing the citation for this slide. I couldn't figure out how to get it on here, but it's from the American Society of Transplantation Infectious Disease Guidelines from 2009. And it gives sort of a timeline of when the different types of infections occur. So it's broken down by infections that come from the donor and infections that come from the recipient, and then the timeline. So early post-transplant, it's usually hospital-acquired infections, so they get line sepsis, catheter-associated UTI, or it may be a surgical site infection or something technical about the operation. The liver transplant patients are at risk for having hepatic artery thrombosis, and when that occurs, they get abscesses throughout the liver, and it's an absolute nightmare because there's nothing good you can do about it. But later on, they'll get activation of latent infections. So if they've, if they're CMV positive, EBV positive, those sorts of things can reactivate. Strongyloides, other opportunistic infections can occur. Pneumocystis, although we never see it because we prophylax for it. And then beyond 6 months, you start seeing more community-acquired infections. And these are examples of the infections some of the stuff we just talked about. The community-acquired infections, you can have late CMV, hepatitis, viral hepatitis, and that sort of thing can occur late as well. But I thought this was a great summary slide. And I included it in your handout because I wasn't sure if I was going to be able to get it to project very well up here. And in your handout, there's also some tables that talk about serologies and prophylaxis strategies that I thought would be helpful for you. So again, we talked about some of this already. These are the types of infections that we see within the first 30 days after transplant. You can, at this point, early on, see reactivation of TB or strongyloides in this setting, and we did recently have a lung transplant patient that got strongyloides. You can get bacterial infections from the donor, so for some reason something happens. I remember I called Dr. Sinnott in the middle of the night because they dropped something. I don't remember, a heart or something. It's like, what do I do?
Whether it's a heart
Exactly. There have been cases of tuberculosis being transmitted by the graft. Obviously, viral hepatitis, the bloodborne pathogens. Syphilis, we do get calls because, we'll get a call post-transplant. Oh, the donor's RPR was positive. What do we do? And then obviously rabies, West Nile virus, and those types of things can be transmitted by the graft. And there's a committee that's working specifically on donor transmitted infections because it's there's some new policies and procedures put in place that when strange infections occur, that information is transmitted back to the organ procurement organization so that they can, go out and check all of the recipients of organs. Because as you can imagine, one donor can supply organs to lots of different people, and if one thing happens at one center and it happens at another center, but it's just isolated, sometimes people don't put it together as, oh gosh, there may be a pattern here. So there's I think the new guidelines will come out with a lot more information about how to manage those types of problems. Unfortunately, they tend to have terrible outcomes, so it doesn't necessarily help your individual patient. And then 1 to 6 months post-transplant, I highlighted cytomegalovirus because that's the main thing that we deal with, but obviously herpes infections, fungal infections, adenovirus, papillomavirus, pneumocystis, Listeria. Usually Cryptococcus is a little bit later, but there's some other data to suggest that it can occur during the same time period, so I wouldn't hang my hat on that. Why do we spend so much time worrying about cytomegalovirus? Well, it causes problems all by itself just because it causes infectious problems, but it has a lot of other effects on the patient. It actually leads to an increased state of immunosuppression. So you've got someone who's already immunosuppressed, and then they get this virus on top of it, and they'll develop superinfection. So you may have a patient present with CMV, and then a little bit later, all of a sudden, they've got Aspergillus. So, it's important to look at the immunosuppression in these patients and talk with the transplant team and see if sometimes they can decrease the amount of immunosuppression. These patients will often present with leukopenia. That will be your first sign in a lot of cases. So, you'll get your weekly CBC, and if it's fine, and it's fine, and it's fine, and then it's 2.3. And it's like, first thing you do is work them up for CMV. But obviously, with a low white count, that puts them at risk for other infections. You get inversion of your CD4-CD8 ratio, activation of latent pathogens that can occur, so toxoplasmosis and other herpes viruses. And then CMV itself can injure the graft, so it can cause vasculopathy. We had one transplant patient who he was a heart recipient. He got CMV vasculopathy and ended up having to be retransplanted for that. And I was just thinking about him the other day. I was wondering if he was still with us. He left the area, so I don't know if he's still alive, but Doug and I took care of him for a long time. How do we treat CMV? Well, we're really lucky because we actually can treat CMV now. When I was in your shoes, we had to get compassionate use ganciclovir, and it was a big deal. We had to fill out all kinds of paperwork and everything, and that same was true for our for our HIV patients. It was like, oh gosh, here we go again. But we have ganciclovir and we have valganciclovir now. And so valganciclovir is a great oral option. It has high bioavailability. So if patients are absorbing well, their gut's working, and they're not too sick, you can often use valganciclovir to treat them. You have to be careful. These drugs will drop the white count. So you've got someone that you're called up because their white count's low, and then you're putting them on these drugs. Generally, their white counts actually get better because treating the CMV fixes the underlying problem. But you want to keep an eye on their white count while they're on these drugs. They have to be adjusted for renal insufficiency. For CMV-IG, we still add it for pneumonia. Not all centers do that, but we do that here. And it also, some centers will do it for other serious disease, or if they're dealing with resistant CMV, to try to, throw everything at it that you can. And then we used a follow-up valganciclovir to prevent recurrence. So it's not written in stone how long to treat these patients. And generally, 2 to 4 weeks is recommended, but you also monitor their clinical symptoms. And many centers will give follow-up long-term, maybe 3 months post treatment doses of a prophylactic dose to prevent recurrence. We were monitoring their PCRs, their viral loads, and trying to make sure that those drop before we stop their treatment altogether. But there's different centers that do it in different ways, and I think some of that might be in the handout that I provided for you. Fortunately, we don't see a ton of invasive aspergillosis, although it's certainly more common in the lung transplant population. Most often it causes pneumonia. It's sort of easy to understand why that would be the case. Sinusitis is another one. About 5% of the cases will present as sinusitis. Cerebritis in 6%, and so they can present with a stroke or nodular lesions, and another 5% will have skin lesions. Generally, you got to work up everything when you find it. So if if a patient presents with pneumonia, you're going to make sure they don't have it in the brain while you're evaluating them. This is the epidemiology. So as I mentioned, it's much more frequent in the lung transplant patient population, and there's several reasons. As you can imagine, the lungs are in contact, so your donor donated organs in contact with the environment with a lung transplant. The other problem is a lot of lung transplant patients are colonized with Aspergillus and resistant gram-negatives pre-transplant, particularly the cystic fibrosis patient population. So they're at risk for developing these infections post-transplant. And then you have a much lower risk in the kidney and heart transplantation. Liver's a little bit higher than those.
You see that those, like the lung is more common infection. Okay.
Yes.
Because I was curious in a way to know what is more common to ask for transplant. Do people look for transplant more common for kidney transplant, lung transplant, cornea transplant? You see, I'd like to know the organ that is most common for transplant.
The most commonly transplanted solid organ transplants kidney.
Is the most common.
Yeah. And there's a couple of reasons for that. There's two kidneys, so you can transplant one kidney into two different, the two kidneys can go to two different patients, so you only need one kidney to function. So that so the most common transplant is kidney by far and away.
But then you see, but what I'm asking is what people ask more frequently. Do people go to look for a transplant more frequent for a transplant of the lungs?
Kidney would be in that category as well because of the number of people that are on dialysis. That's probably the most common. So kidney would be the one that most people need, and they're the most transplants. Because the other thing you can do is you can take a kidney from a live person and donate it into and transplant it into someone. So there are a lot of living related or even unrelated donors that provide kidney transplants. So there's a lot more. There are more organs available for kidney transplantation, and some centers do up to half of their transplants are from living donors. That's not the case here. We're probably about 20% of our transplants are from living donors, and we're actually that's one of the things that we're working with our transplant team to try to increase the number of living donors for kidney transplantation.
But having said that, when you do an effective isolated one kidney faces significant complications, hypertension, diabetes, anemia. So are we ethically justified in taking away a kidney from a donor who will discuss giving other extra?
Well, I think that's a very good question. Right. Well, actually, there's a fair amount of data, especially now, because we've been doing it for a long time, to look at the long-term consequences of taking a kidney from someone. And generally, people do well. But there are databases, and they are looking at that because that's a very good question. And we don't always have good follow-up data on the donors to know, what happened 10 years later. So there are registries that are following those people to try to assess that. But it's kind of interesting to me because we've all watched the news and seen, someone will see a story on the news and a perfect stranger will say, oh my gosh, I'm going to see if I can donate my kidney to that person. And I'm thinking, well, that's very altruistic of you.
Because they don't understand the implication of donating a kidney to themselves.
Well, and
We as physicians don't make it very clear to them.
well, I think we actually there's very strict rules about how that evaluation is done, and the physicians that are talking to the living donor can't be part of the transplant team. So we to try to not have coercion or a partial story given to the person making that decision. But I had a patient that donated a kidney to his son and then went into renal failure. So it happens. It's a risk. It's absolutely a risk. And I think if it's a parent and child, they're willing to take that risk, and you'd do anything for your child, and that's one circumstance. But the people who donate to perfect strangers, I respect them for being so altruistic, but I wouldn't do it. Just my personal opinion, but
What about the partial organ donations? Like in liver, you have partial organ. Is there a technology for partial kidney because you do partial nephrectomy? Like it can survive.
I don't know anything about, I haven't seen anything about partial donation for kidney. Obviously liver and lung, but I haven't seen it for kidneys.
The new technology developed with the solid organs in the lab.
Yes, yes.
Much more advanced in London and Switzerland, Netherlands than we've seen in the States. But in the States, they developed with arterioles. And that's sort of the transplant. That's pretty much now a norm, isn't it? They developed the trachea, the stem cell implant on them. They developed those organs.
Yeah, I'm not sure that they've got it in a three-dimensional, they can grow these things in a flat plane, but not all of them, they've been able to figure out how to make them grow in 3 dimensions to literally recreate an organ. So they're working on those things, and it's promising, but we've got a ways to go. And there are people that are using stem cells to directly implant them into organs to see if they can, reconstitute the in situ organ, and so that's another potential option. So how do we diagnose Aspergillus infections? This can be difficult. Some of the studies that have been done, looking at sputum, only 16% of patients who had proven invasive aspergillosis had a positive culture, 56% with probable invasive aspergillosis. I think I said that backwards. That seems backwards to me. Right. Yeah, that's what I'm thinking, and that doesn't make sense to me. So, I apologize. I'll have to go back and look at that. In bronchoalveolar lavage with transbronchial biopsy, 83% of those were positive with proven or probable invasive aspergillosis, and galactomannan assays I don't think have been useful for us. I never used them.
I still get them every now and then, but they don't want any help.
Yeah.
They never change your mind.
No.
Right. So the bottom line is up to 20% of the cases are diagnosed post-mortem because we have difficulty making the diagnosis. Treatment for Aspergillus, first line is we try to reduce immunosuppression as much as possible. If patients are neutropenic, then we may give them GCSF. You can consider intravenous immune globulin. We think about, are there other cofactors? Could the patient have CMV? Should we consider debulking? Is it a solitary lesion that we can remove? And obviously antifungal therapy. And in all honesty, our antifungal therapies are so much better than they were that we usually don't have to resort to some of these other measures. When we just had old-fashioned amphotericin B, we were desperate. Remember the resistance patterns for the antifungal agents with fluconazole, Candida krusei, glabrata, and the molds are going to be resistant. For amphotericin B, the Candida lusitania, Fusarium, Scedosporium. For the echinocandins, Cryptococcus will be resistant, and for voriconazole, the zygomycoses. How do we evaluate pulmonary infiltrates? One of the things we have to think about is what is the differential diagnosis, and this is for Dr. Sinnett's sake because this is one that he taught us. It includes his ache, mnemonic, but you want to think about rejection. If someone's had a lung or a heart transplant, either one of those can show up as a pulmonary infiltrate. If they're rejecting with the heart, it may be due to heart failure. And obviously the lung is due to the lung rejection. Volume overload, did they have a pulmonary embolus? Could they have aspirated? One of the things that we struggled with when they first started using Sirolimus is they would get pulmonary infiltrates and fever, and we'd go on this wild goose chase to try to figure out what was going on, and then we finally say, well, it must be the Sirolimus, and they'd stop it and they'd get better. And then if it's infection, what do we want to do? So we obviously, if we can get sputum studies, sometimes we can't get sputum, as you well know. We want to move quickly to bronchoscopy or even thoracoscopic biopsy if we need to make a diagnosis. If we don't make a quick diagnosis and get them started on appropriate therapy quickly, they do not do well. So we tend to be invasive with these patients. And then start empiric antibiotics when you want to cover your typical and atypical organisms, obviously. We have an immunocompromised protocol for bronchoscopy, and I'm going to have to rely on the audience to help me a little bit because I think some of these things have changed a bit. Obviously, we get our gram stain and bacterial culture, fungal cultures, AFB smear and culture, the nocardia, Legionella. I believe we're starting to do PCR more for the respiratory viral pathogens, and obviously silver stain for pneumocystis and cytology. And so the nice thing is that this thing is in a package, and we can, the pulmonologist can just write for of course now we don't write, we epic, we point and click for the immunocompromised protocol so that the studies get done, so that, it's nothing is more frustrating than to have somebody do an invasive procedure and you didn't get all the studies done that you want to do. So we have our, folks who develop these protocols to help make sure everything got done properly. Then the patient gets, 6 months out from their transplant. So what kinds of things are they going to have now? Well, they tend to get more common, community acquired things like diverticulitis, but diverticulitis doesn't look the same in the transplant patient as it does in somebody else. So you have to maintain a high index of suspicion because they don't necessarily have the hot belly and all that. Cholecystitis, TB can occur whenever it feels like it. The endemic fungi may show up now. Post-transplant lymphoproliferative disorder can appear early or late. It tends to have sort of a bimodal distribution. CMV retinitis tends to be a late manifestation of CMV. I've seen it once. I don't know how many times, and it was when I was a fellow, I think. And then the community-acquired infections. So when you're dealing with these patients, you want to think about infection and then think about the timeline. So one of the first questions that we'll ask, call up with a consult. They've got a transplant patient with fever. How long has it been since they've been transplanted? Helps you try to figure out what their risks are. What is their CMV status? And what kinds of exposures have they suffered? Could they be rejecting? Could this be some sort of drug reaction? Again, back to the careful H&P or screening labs and diagnostic studies. You want to start empiric therapy. Keep in mind the drug toxicities and the drug interactions that we talked about earlier. And then my last is the pitch to talk to patients about organ donation. There's a desperate need. If you're taking care of somebody, and you guys take care of a lot of patients in the neuro ICU, and it looks like they might wind up being a potential donor, then I tell you, don't talk to the family. At that time, if you identify someone who's a potential donor, the best thing to do is to get in touch with LifeLink, and they will send people to talk to the family. The people who have those discussions are specially trained in how to approach the family, and their success rate is significantly higher. When the doctors get involved, we screw it up every time. So it's really important, if that occurs, to get in touch with LifeLink, and the nursing staff know how to do that. And that concludes the talk. Are there any questions? There's so many things